My name is Darren Kies. I am the Section Chief of Interventional Radiology for Piedmont South Imaging. Y90 is just kind of a colloquial term we use for yttrium-90 radioembolization. So that involves the delivery of intraarterial microspheres that are have either Y90 embedded or on the surface of the particles into the liver for the treatment of primary and secondary liver cancers. The term radiation lobectomy refers to the lobar administration of Y90 with the intent to not only treat the tumors that are in that lobe of the liver, but also to grow what's called the liver remnant. This procedure kind of came into, it was basically an observation that when patients were treated with Y90, oftentimes on follow-up imaging, you would see that the treated lobe would undergo some degree of atrophy, and the untreated lobe would undergo some degree of hypertrophy. So by escalating the dose, folks were able to show that you can actually further induce hypertrophy of the contralateral liver. So the way that this procedure is performed, you can use it using either glass or resin microspheres for Y90, but you definitely want to escalate the dose that you deliver to the patient. We target at least 150 gray to the treated side of the liver, and you deliver a lobar dose of Y90. The advantages of a Y90 radiation lobectomy for growing the liver remnant versus, say, another standard procedure called the portal vein embolization are a couple. And I think the most important one is that it is an oncologic procedure. You are treating the malignancies that are present within the liver, whether they're liver metastases or primary liver cancers. You're offering a treatment that will hopefully prevent them from progressing. In addition, it takes a little bit longer to grow the contralateral liver when you do a radiation lobectomy as compared to a portal vein embolization. However, sometimes that additional time, it can take about 3 months as compared to 4 weeks for a portal vein embolization. But that additional time is kind of a test of time for the patient. You know, if a patient is going to progress rapidly within the liver in the course of 3 months, you know, the reality is they probably weren't a great candidate for liver resection from the get-go, and they were probably going to progress despite, you know, undergoing a huge operation. So, you know, not only are you treating the tumor, but you're also putting the patient through a short little test of time to see what their tumor biology is like and see if they're going to progress on the other side of the liver. And then over that 3 months, if the liver grows to, you know, at least a 20 to 40% threshold, depending on your patient, they will be set up for a proper hepatic resection.